Welcome, knowledge seekers and professionals, to the channel of the Swiss Journal of Radiology and Nuclear Medicine. A quick heads up, the following audio does not include any images, tables, or other additional information. If you're interested in the following paper, please visit our website listed in the caption below. Now let's get started. Today, we're going to dive into the scientific publication with the title Magnetic Resonance Imaging of a Rare Case of Primary Choriocarcinoma of the Vulva by Babu Peter Satyanathan and Venkatakrishnamarali Maheswari Mridhula. Patient and observation. The patient was a 26 years old female who presented with complaints of menorrhagia. She had undergone suction evacuation for partial molar pregnancy 4 months ago, which was confirmed by histopathological examination. Following an initial decrease in serum beta human chorionic gonadotropin in the first month following the procedure, she had failed to follow up, and the beta human chorionic gonadotropin level at the time of presentation was 30,292 international units per liter. Magnetic resonance imaging of the pelvis was done using 1.5 Tesla MRI. Standard institute protocol was followed. Signal acquisition was done using phased array body coil. T1 sagittal, T2 axial, sagittal and coronal, 3D space T2, short tau inversion recovery coronal, T1 weighted fat, suppressed axial and dynamic contrast enhanced images, and axial diffusion, weighted imaging, and gradient sequences were used. These revealed a well-defined mass lesion in the right sublabial region, measuring 3.6 times 2.8 times 2.4 centimeters in its greatest dimensions. On T1 weighted images, the lesion was predominantly hypointense, with few internal hyperintensities. On gradient images, these T1 hyperintensities showed blooming, indicating that these were areas of hemorrhage. On T2 weighted images, the lesion was heterogeneous, with predominant hyperintensity and a T2 hypointense rim. Few flow voids were noted in the center of the lesion. Few peripheral areas of restricted diffusion were noted on diffusion weighted imaging. The uterus and adnexa appeared normal. On contrast administration, there was intense peripheral enhancement of the lesion, especially in the regions of restricted diffusion. Intense enhancement was also noted in the center of the lesion, where flow voids were observed on T2 weighted images. Few confluent non-enhancing areas, which were hyperintense on T2 weighted images, were also observed, indicative of necrosis. There was no evidence of invasion of the vaginal wall or enlarged pelvic lymph nodes. Chest X-ray was normal. In view of the clinical presentation, elevated beta human chorionic gonadotropin and imaging findings, a diagnosis of choriocarcinoma of the vulva was made, and she was started on chemotherapy. Beta human chorionic gonadotropin decreased progressively to 464 international units per liter following the first cycle, and subsequently to 0.32 international units per liter following the fifth cycle. The patient is currently asymptomatic. Follow-up MRI was done to check for any residual lesion or sequelae. This revealed a normal uterus and adnexa, with no abnormal significant residual lesion in the vulva. Discussion. Gestational choriocarcinoma is a malignant form of gestational trophoblastic neoplasia and can be associated with any type of coincident or antecedent pregnancy. Extrauterine choriocarcinoma is extremely rare, and the cervix is the commonest site. Only 4 cases of primary vulvovaginal choriocarcinoma and 2 cases of primary vaginal choriocarcinoma are found in literature, with imaging features described only for purely vaginal lesions. The commonest presenting feature is abnormal vaginal bleeding with elevated beta human chorionic gonadotropin, as seen in our case. These lesions are usually hypointense on T1 weighted images with internal areas of hyperintensity indicating hemorrhage. On T2 weighted images, they are heterointense with a hypointense rim. On contrast administration, they exhibit peripheral enhancement with non-enhancing areas indicating necrosis. The imaging features in our case are similar to all the features thus described. These masses are highly vascular, as evidenced by the flow voids and avid enhancement in the center of the lesion in our case. Choriocarcinomatous lesions contain abundant venous plexus without valves, which makes them prone to torrential hemorrhage, due to which biopsy is not routinely advised when beta-human chorionic gonadotropin is rising or elevated. These tumors are also highly chemosensitive and carry a good prognosis if treated. In our case, too, there was a significant fall in beta-human chorionic gonadotropin following the first cycle of chemotherapy itself and complete resolution of the lesions post-chemotherapy. Conclusion: primary choriocarcinoma of the vulva has rarely been reported, and review of literature revealed no case with MRI features has been reported till date for choriocarcinoma involving only the vulva. An awareness of a lesion in the labial region being due to an extrauterine choriocarcinoma in a patient with elevated beta-human chorionic gonadotropin is crucial to guide management and aid in complete recovery from this potentially fatal malignancy. Our case is also unique, as we highlight the pretreatment MRI features as well as post-treatment imaging follow-up. We have come to an end. Thank you for listening in, and until very soon with more interesting publications. If you want to share your own paper in our journal, feel free to contact our team. We are looking forward to hearing from you. Don't forget to like and share if you enjoyed this content. Click the subscribe button so that you don't miss out on future publications from the Swiss Journal of Radiology and Nuclear Medicine. Until next time.